I wanted to welcome everybody that has joined so far, and we are super excited to sponsor this webinar on Hook Splint, this time with a focus on evaluation, tips and tricks. Look out for more upcoming webinars on either North Coast Medical social media or under the events tab on the NCM website. This live webinar is being recorded, and it will be added back as a pre-recorded webinar to allow for easy sharing with colleagues. And you'll actually be able to, anybody can actually put their information in once it shows up as pre-recorded and actually watch it on our website. Anyway, without further ado or delay, I wanted to welcome our presenter, an OT, CHT, and also the co-founder of Hook Splint, Chavi Perelman. Take it away. Thanks so much for being here today.
Perfect. Hi, everybody. Thank you for joining. And thank you to North Coast Medical for putting this webinar together. Very exciting. So today we'll go over the Hook Splint co-founders, some background in relative motion, some issues we were having with relative motion orthoses that led to developing Hook Splint. Then we'll go into Hook Splint itself and talk about its unique materials, how to size it, how to fabricate it, and how to do it as an anti-claw, some reasons you would use it, and then we'll cover some billing. So as we mentioned, I'm an occupational therapist and a certified hand therapist. I've been working in upper extremity rehab for about 10 years. I currently work with Dr. Solomon, who's a board certified orthopedic surgeon. And so together we developed the Hook Splint. And so this is my official product disclosure on my association with Hook Splint. So first we'll go over the basics of what is relative motion. So relative motion is the concept of placing one finger above or below the other fingers. So it's relatively extended or relatively flexed compared to the other fingers. So you can see in the example here, the middle finger is above the other fingers. So it's relatively extended in relation to the index and ring finger. So you can see the front view and the side view there. So how does it work? So the first concept is called the quadriga effect. You might have heard it in relation to complications for a tendon repair. Here it's used for a positive aspect where because the tendons all come together and have a joint muscle, when you put one of the tendons backward, the muscle's working the same, but because it's backward, that finger that's backward is not getting the same amount of stress as the other fingers. And so that's the quadriga effect. The other concept of how it works is called redirecting motion. So if you place a finger, let's say above, every time you bend by blocking this knuckle, you're now getting that flexion force here first. The same concept works if you're trying to straighten your finger. By blocking that finger downward, every time you straighten out, automatically your force is going into that middle knuckle. It's a similar concept to joint blocking where you hold this knuckle so all the energy goes here and is redirected here. So relative motion kind of just like puts it into play for you. Another reason that it works is from rebalancing structures. So by putting it above and below the other fingers, you could be preventing a tear from getting worse. You could be preventing the pain just by kind of shifting where it is in place. So relative motion, we all love it. It's a great concept. The issues we were having though is that it wasn't as functional, low profile as it was made out to be. We were hearing patients were saying it's uncomfortable. You know, it sits in a very sensitive area, so when it rubs, it's super uncomfortable to wear. Patients were saying it was bulky. It was getting embarrassing to wear because it was so noticeable. We tried to do like a closed design, like figure 1, and then patients couldn't take it on and off with swelling. So we tried doing the open design with Velcro, and then it was getting too dirty and patients couldn't clean it properly. Fabricating itself wasn't as simple as it should have been. You know, we had a hard time getting the right level of lift. We found that there was a lot of skin maceration because of the lack of breathability. It was hard to clean, and so overall not very functional. So Dr. Solomon and I figured there had to be a better way. and that's what led to the Hook Splint relative motion orthosis. It's made of a smooth silicone with an Apple Watch feel, so the outside has like a UV coating. The inside gets rigidity from metal, from stainless steel metal. And it was also just so easy to fabricate. All you have to do is take it out of the package, put it on, done. We loved that you don't have to use any form of heat, so you don't need a heat gun, you don't need a hot water bath, you don't need any splinting experience because it's relatively straightforward. It's waterproof, washable, and we'll go over the open loop design soon, but you can see you can basically turn it around where you can use it for both flexion and extension because of how it's totally open in the middle. So how much lift does it have? We did this under X-ray to see how much lift we were getting, and it showed we were getting about a 30 to 31 degree lift, which is more than enough lift for most diagnoses that we're treating based on the literature and experience. So I'm going to go over the different sizes of the Hook Splint. We first launched with the small medium. So if any of you had samples when we first launched, yours is going to be the small medium. It's a much more flexible metal. We were hearing feedback from the people saying that we wanted more rigidity. So that's when we launched the large, which is not a ton longer and wider than the small medium because we're working with the small surface area of the hand. The major difference was the rigidity. So you can see how much harder it is to bend. And then we came out with the extra large that has even longer length for the super large hands that has even more overlap when you put it on. And it can also be used as an anti-clock, which we'll go over a little bit later. And then soon we have an even longer size coming out that can be used as an anti-claw on any size hand. Sorry. The extra large can only be used as an anti-claw on a smaller hand. We have a sizing chart here. You basically just take a measuring tape, which most of you have in the clinic, and just measure right around this area, around the metacarpal heads. And you see which category it falls under. Now, I do want to point out, though, that if somebody falls into the small medium range, but they need a greater lift, more rigidity, they're going to be wearing it for more than 30 days, size up to the large, because the large has that extra durability because of the thicker metal, and it definitely works on smaller hand as well. So we're going to go over how to fit it and apply it to the patients. So it comes in one of these bags. You just take it right out. If you need a little reminder, they do have these. You just open it up and give yourself a little reminder of how to do it. We'll do it with a small medium first. And you put whichever finger you're working on. So let's say we're doing the middle finger on extension. We'll put it into extension, fit it onto the finger. Now, you want to make sure that that it's not too tight and scissoring. If I made it like this, you can see my fingers are pulling inward. It's not very comfortable and it won't be very effective. But you also want to make sure it's not too loose, because if I did it like this, you can see there isn't a lot of lift. It's too much room. So let's pick the hole right in the middle. You have the patient just make a couple fists, see if it's comfortable. And then if the sizing is right, you take it off. You take this tab here, the first tab, and you can see you can either bend it toward the circle or toward the loose end. You want to bend it toward the circle so that it doesn't start to bubble underneath the loose end. So you can just use your fingers. If you have issues with dexterity, you can always use a tool like forceps, needle nose plier. But the small medium is definitely soft enough metal that you could manipulate it with your hands. So you see the first one is just butt in toward the circle. You take that loose end and just follow it around. And this one just gets a simple fold inward. And then you just put it right back onto the hand, make sure it feels comfortable and good. And you'll see on the next slide that how the inside tabs should look. So you can see in the picture, you can see on the picture where the first tab looks like this, and the second tab is folded inward. You want to make sure that that's like that, because if you leave any of the tabs just like hanging out on the outside, they could potentially get snags onto things, or the fidgety patients can start to play with it. So you want to make sure that both of the tabs are nice and tucked underneath. If you felt like you want it to be more flush than it is, you can take your tool here, needle nose plier, and just cinch it in to get even smoother feel. And you can do the same thing for that inner tab. Do a little curl and a little cinch, and then super flush. I would make sure that fit is good for the patient before you start cinching it, but even if you got the sizing wrong, you can easily just take it back out and redo it. I wouldn't recommend the patient undoing and redoing every day, but definitely to get the sizing, and definitely if there's like a change in swelling, you can easily open it and close it up. So some tips, you can see that there's a double layer and a single layer. So if the patient just needs like a little lift and the goal is accomplished with a single layer, totally go with the single layer. I'm just going to refabricate this quickly to show you. But if you felt like they needed the greater lift, we would do this side. Otherwise, the single layer. If someone wanted to do a combination, it's flexible with how much lift you do there. And like I said before, you can use needle nose pliers if you need for the thicker materials, because these tabs you can see are not as flexible. They might hurt the fingers. So for the large and extra large that have the more rigid metal, you'll see how I do this later, but you'll want to use a tool. Perfect. Let's see the next slide. So the extra large, like I mentioned before, can be used as an anti-claw. You can see here the before and after. Traditionally, it's thought of as for patients who have an ulnar nerve injury, but it can also be for patients who just have a stiff small finger PIP contracture where you're not getting enough of a push with a relative motion orthosis, and you don't want to have like a whole big bulky regular orthosis. So you can you can think outside the box and not use it just for the ulnar nerve patients, but any patient who might have a small finger, ring finger, or technically an index or middle finger as well, that needs a little bit of an extra push that you need to put the palm in to get that. So for that, I don't know if other therapists can relate, but we were having similar issues with the relative motion orthosis that we were with the anti-claw. Again, it's a small device, so simple, but patients were still finding it uncomfortable, not so functional. So this was the next one on our radar to bring another option to. So that's how we came up with this. So you take this, you just put it on the back of the small and ring finger, cross it over the palmar side here, and then find the hole that meets it. And so for the tab part, we'll take it off. So here's where you'll see the needle nose pliers. So you're going to take that first tab and you're basically just buttoning it into the next hole. So you can see it here. And then I'm just going to cinch the other side through so it's flat. And then the second tab here, we're just going to fold inward, that simple fold. Because the large and extra large metal is stiffer, it kind of sits a little stiffer as well, a little more rigid. And then all you do, slip it back on. Right through the holes. You can cinch it back into place for the patient. And then there's our anti-claw. And let's see the next slide. So most of you are probably familiar with using the relative motion orthosis after an extensor tendon repair. That's why Dr. Merritt originally came up with the concept. But we're going to go over some other reasons that you can use it, and specifically relative extension for this slide, and then we'll go over for reasons to use it in relative flexion. So extensor tendon repair, it's used to hold the finger backward so that when you bend, this finger is still on slack and isn't getting that full force, protecting a repair here. Similar concept with the sagittal band injury. You can see in figure 1 and 2, there it's used to help the patient bend the finger. So you can see in the first picture, he has a very stiff finger. He has an extension contracture. We can't quite bend it. And just by giving it that lift, you're repositioning it so every time he bends, the force is going right into that knuckle and helping it bend. So just by repositioning it, it helps that small finger bend. You can see in figure 3, there we use it for a patient who had a mallet and a swan neck deformity. So his PIP was hyperextending backward. So of course he needed the mallet splint here, but in order to prevent that swan necking from happening, just by putting it backward, the finger automatically gets some slack there, and it prevents that. It actually makes it impossible for it to hyperextend there. Figure 4 was a similar concept with a PIP dislocation. She had a hard time bending it, so just by positioning it backward, all of a sudden that force was just helping it bend more. We also love using it for radial tunnel syndrome. I don't know if you guys are familiar with that, but it's basically pain in the proximal forearm here. And by putting the middle finger backward, you're relieving some of the pressure on the radial nerve there. And that's been like a game changer for those patients who don't have a lot of treatment options. It's also used for after a flexor tendon repair, not directly after the repair, but once they're cleared for differential tendon gliding, it kind of sets the finger back to allow the FDP and FDS to kind of glide separately. And it's also been recently studied and used for rheumatoid arthritis. You'll notice the references here are super up to date because a lot of research has come out this month about using the relative motion orthosis for different uses. So that's been very exciting to read through. So now we'll talk about using the relative motion orthosis in flexion. So the most common use probably is for a contracture of the finger, or the middle knuckle is having a hard time, of any of the fingers is having a hard time straightening out. It happens very commonly after injuries where it kind of just like sits like that, it gets stuck like that. So by putting the knuckle downward, now every time I straighten out, my extension force is going into that middle knuckle first because it's being blocked by the knuckle behind it. So we see this concept with after people have a trigger finger release or a PIP dislocation, Dupuytren's release. We love it for boutonniere deformities. So you can see in figure 3, a patient had a boutonniere deformity, and by pushing, classically it's been just immobilized, and it's been a very, very hard thing to treat. But with the new research out, just by putting it into flexion, the central slip is able to heal and get the same effect more functionally. And you can see in figure 2 how the patient has a PIP contracture of the small finger. It wants to go outward like this. It wants to hyperextend at this knuckle. So by putting the relative motion orthosis on, we basically push the knuckle downward, redirected the force from the MP to the PIP, and instead of it kind of drifting outward, it's also more realigned now. It's also a very welcome treatment idea for someone with hand pain. You know, we get these patients who come in with the imaging is clear, everything's clear, but for some reason their hand is hurting. So we just kind of do a little bit of a trial and error with seeing, you know, does this feel better? Does this feel better? So this can really be flexion or extension just based on testing different positions. And that's been such an amazing change to that unknown hand pain treatment. Another thing that's kind of like hot on the press, but not officially enough research to cover, is the flexor tendon repairs right after the repair is done. You know, now it's such a strict protocol. It's so delicate, but hopefully we'll see more research on that and using it with early active motion. So I touched on this a little bit before, but we wanted the Hook Splint to be an open loop design. First of all, to accommodate any sort of finger swelling so that you can still take it on and off easily. Another thing we had in mind was if someone's stiff in both directions, which happens very commonly, they can have a combined wearing schedule. So you can see in figure 1, this patient had stiff fingers in both directions. She actually had all her fingers stiff, so we had lots of different configurations she was switching between throughout the day. But you can see she started off like this with these two on top, and then throughout the day she would switch it. So up there on the bottom, it's super easy to flip around. And another thing I wanted to point out was border digits. So we get a lot of questions like, can this be used for border digits? So I wanted to show you that, as you can see here, it's being used for border digits. You basically just have to use the opposite border digit with it. So if, let's say, we were working on small finger PIP flexion, you just kind of wrap it with the index finger as well. And similarly with if we were working on PIP extension, you would also just keep the index finger in it. And that's how you do the border digits. So a quick screening you can do to see if your patient is a good candidate for it is called the pencil test, which was introduced by Dr. Lalonde. You basically just take a pencil, preferably a Hook Splint one, and you just put it in a position that you think might help the patient. So we talked about hand pain before. So, you know, if there's a clue of which finger is causing the pain, you can start with that finger. So just, does it feel better, worse, or the same? If it feels better, great, you hit the jackpot. If it doesn't feel better, try putting it in relative flexion. Does it feel better, worse, or the same? If it still doesn't feel, it feels a little bit better, okay, let's try doing the ring finger with it. Does this feel better, worse, or the same? You want to kind of just do any combination of fingers, positioning, and just see which position feels the best, and then you can just get right into positioning it. It's just a faster screening than doing relative motion up front. And it can even be used, you know, if someone has like a snapping sagittal band, or the tendon snapping because of an injured sagittal band, you can just put that finger backward and bend the finger. Does it feel better? You can just look at it. Is it snapping? And that it's just a quick screening that you can view as well. Let's go to the next slide. Billing, our favorite part about being a therapist, but it is a part of the job. So for relative motion orthoses, you would bill the L3933. For an anti-claw, you would do the L3913 because it goes into the hand, the palm of the hand. Now, it's basically a piece of splinting material that can be used for anything with a rigid core. So even though it's not heated traditionally, it's the same concept. So, but obviously that's just our recommendation. It's ultimately up to the healthcare provider, whatever you feel the most comfortable with billing, that would be the best thing to bill. Some clinics might choose to do cash and carry where the patients just kind of like pay for it and take it home. It's really up to you which route, but those are the recommendations. Here's our little shameless plug for social media. We're both North Coast Medical's account and Hook Splint's account. We're both always posting fun ideas, new products. So definitely, you can actually take your phone now. Well, wait, I'm just kidding. Whenever you want to, you can hover over those QR codes and see our social media platforms. So I wanted to see if anybody had any questions or comments. Let's check the chat box.
So far, I don't see any questions except will we be emailing this presentation? And I provided a comment in there in regard to the fact that if you email me at rfilmer@ncmedical.com, I'll be definitely happy to email the presentation on. Let's give it another minute. As part of this presentation, we do have some frequently asked questions where I think we've kind of covered them all in this presentation. Javi, great job, by the way. Thank you so much. But those frequently asked questions will be part of the presentation. So if you'd like to get them, you can. I don't see any questions. So that's an amazing job. In under 30 minutes, you were able to get through all that information and answer everybody's questions at this point in time. For those that have registered for the webinar, give us about 2 or 3 days and we'll be sending you an email with this video link. And that might help. I know some of the movements that Javi was making were quite intricate. And if you want to use a video and stop and pause and go back to see exactly what she was doing, that'll be available in a video just a few days from now. So unless there are any other questions, oh, here we go. We've got a question. Will the extra large version be available in Germany?
Definitely shoot us an email and we'll work on getting it to you in Germany. And also, by the way, you can see some of these, if you need it more close up than you were able to see on this webinar, North Coast Medical has a video tab on this product where you can see YouTube clips on, you can follow it here, you can see YouTube clips on how to fasten it, border digits, yeah, all the most common questions that you guys want, you can see on our YouTube channel or North Coast Medical's website.
Wonderful. Well, thanks again, Javi. We really appreciate it. Thank you, everybody, for joining.
Of course. Yes, thank you so much.
look forward to another webinar soon when the extra large comes out maybe, huh?
Yes, you bet.
All right, thanks so much.